So the theory of the CO diffusion is that it's a measure of the CO transfer from airspace to pulmonary capillary blood. But at this time, please remember, we are not really interested in CO, but we are interested in the transfer of oxygen from airspace to capillary blood. But this measurement would be invasive. So the standard became CO because it's non-invasive, and we only have to measure CO in the airspace. So the unit is expressed by the unit of time and unit of driving pressure of CO. So the diffusion measurement itself in the last time became standard to have fast gas analysis compared to the classical method where we used slow analyzers. We now have fast gas analyzers, and we get a lot of more information based on the same principle and the same test. So now the clinical interpretation of the measurements. Characteristics of the diffusion capacity are diseases which cause a decrease of the diffusion capacity. That's globally emphysema or the loss of parenchymal tissue, interstitial lung disease, pulmonary vascular disease, global insufficiency of the lung, and this is very often the cause why diffusion testing is used, because it is very sensitive to starting to initiate diseases of the lung, and it gives them global information about the situation of the lung. And there are diseases which usually don't alter diffusion, except the inhomogeneity of the lung is large and is significant. And these diseases are asthma and bronchitis, neuromuscular disease, or chest wall diseases. A short overview about the diseases. And now I'd like to discuss a point which usually is not known, because usually in clinics, the diffusion capacity, the parameter diffusion capacity, is interpreted as diffusion capacity itself. And in this graph, I'd like to show that this is not so simple as it seems. Look, if you look at the inhomogeneity of the lung, or if you have an inhomogeneity indicator, here this scale shows the inhomogeneity of the lung. Here in this field, it's normal, and with decreasing value, there is an increasing inhomogeneity of the lung. That means a ventilatory inhomogeneity. And that means if you look at the graph here, this is the DLCO in percentage of predicted. Only if there is an homogeneous lung, that means no inhomogeneity, values of DLCO above 70–80% are in the normal range, and measurement results below 70–80% are abnormal diffusion disorders here. But as soon as inhomogeneity of the lung is increasing, more and more the inhomogeneity is determined the diffusion capacity. That means the diffusion capacity, the value, the test results of the diffusion capacity more and more expresses the inhomogeneity of the lung, and no longer the diffusion of the CO between alveolar space and capillary blood. This is important in the interpretation, because if there is a high degree of inhomogeneity, DLCO is expressing the inhomogeneity of the lung. There is very often another question. The DLCO is one value. you have one test result, and the question is, there are two components which determine this test result. This is the membrane and also the capillary blood volume, and which of these components dominates. And in this study, they found out that in the DLCO, the capillary blood volume is dominating in its value, and less influence of the membrane. That means that if you like to get more information about the membrane, you have to use other methods. For example, the NO/CO diffusion capacity, which also determines the component of the membrane. So now DLCO in the background of the COVID-19 pandemic. There is a clinical study by Mo, and he studied COVID-19 patients at the time of hospital discharge. And his test results, of course, he could very well differentiate and classify the disease, the degree of disease by the test result of the diffusion capacity. That was no problem. That's the first result. The second result is that COVID-19 patients very often or usually suffer from diffusion problems beside ventilatory limitations. But in his study, he found that the KCO, which is mathematically the DLCO divided by the alveolar volume, was even better and did not correspond to the classification based on DLCO. And he said, he was the opinion that the KCO is a normalized by lung volume DLCO, which is not correct, because already Hughes gave the information that the KCO is not a DLCO which is corrected for lung volume. And let me look at this issue further. In this screen, you can see that if you have a healthy lung, there's no problem. You can measure the DLCO and it will express the diffusion of the lung. If you have a loss of alveolar units, it's also no problem to calculate the test results, because, for example, half of the lung is resected, then you have only 50% of the alveolar volume here. The KCO will be 100% because it's the relationship between the DLCO, which is half, also 50%, and the 50% of alveolar volume, so it's 100%. This is no problem. But the problem appears here because there is a nonlinear relationship between lung volume and also surface. For example, a cuboid, and like here, and you cut the edge of half of the size before. And then the volume is only 1/8 of the basic cuboid, but the surface is only 1/4. That means in relationship to the volume, the surface is increased. And this has influence on the test results. For example, you can express this simple example by suboptimal alveolar expansion. And then you can see that if the alveolar volume is 50%, the same like here, the DLCO, because of the increased surface, is larger than 50%, and also the KCO is above 100%. And that was discussed by Chapman. He also took the clinical study of Mo, and he could show that if the alveolar volume decreases, of course, be based on loss of alveolar units, the DLCO decreases as well. And also because of suboptimal alveolar expansion, the DLCO is decreasing. But you can see that the COVID patients were less than the expected way explained by the alveolar volume. And here's the same for the KCO. And you can see a thing which is important. It is possible that though the DLCO is decreased, the KCO is increasing. And so this value is misleading if you don't see it in the contents of the alveolar volume. And what we have learned from this study is that COVID-19 patients suffer from diffusion problems, and these diffusion problems are also not only based on the volume, the alveolar volume, but also on the membrane component and the capillary blood volume. And if you like to differentiate both components, it is necessary that you use other tests, for example, the NO/CO diffusion testing. I summarize. Impaired DLCO is the most common abnormality in discharged patients. In ambulant patients, DLCO can be impaired without pulmonary obstruction. That means DLCO is an earlier indicator of the disease and the degree of disease compared to spirometry, for example, or body plethysmography. On recovery from COVID-19, it is important to draw attention to pulmonary diffusion testing and considering the values DLCO, KCO, and alveolar volume equal and in parallel. That means you have to look at all the three values and not to reduce it to KCO and think this is normalized by alveolar volume. Symptomatic subjects affected by COVID-19, including mild disease, should benefit from a pulmonary follow-up. That's recommended, including spirometry, body plethysmography or IOS, and diffusion capacity measurement and blood gas analysis. I summarize my presentation. The diffusion test is very well standardized by the ERS and the ATS, and I think also in India you follow these standards. The properties of the DLCO measurements are structural properties of the lung, that means the gas and the blood phase, but also functional properties, and don't forget the functional properties, which is the level of ventilation and perfusion and their distribution. We discussed this before. And take into consideration, this is my question and my recommendation to you. The test results for DLCO are not only depending on the physiological characteristics, but on the methodological specifications as well. That means if you change the method, inspiratory time, expiratory time, breath hold time, that will change the test results. It's not only a physiological background. With increase of pulmonary inhomogeneity, there is an increasingly representation of the DLCO by the inhomogeneity of the lung. That means only in, say, homogeneous lungs, the DLCO is clearly representing the transfer from airspace to capillary blood volume. But as soon as the inhomogeneity of the lung is increasing, DLCO is representing more and more the inhomogeneity of the lung. And it is important to understand that KCO is not the DLCO simply corrected for lung volume. It's more complex, and that's why for the clinical interpretation you have to incorporate in the clinical interpretation these three parameters. That's the DLCO, that's the alveolar volume, and also the KCO. So many thanks for your interest and many thanks for listening to me. So my second talk concerns impulse oscillometry, the method, the clinical application of forced oscillometry. And I remember that I guess 25 years ago, I already had the possibility to introduce the oscillometry in India. I was in Mumbai and presented, we had a conference, and I think that was the start of oscillometry in India. So what I'm talking about now is oscillometric lung function testing, and that means nothing else than the evaluation of lung function in about 15 to 30 seconds of normal breathing. That means it's an effortless examination. There are no breathing maneuvers required. You have no shutter or valves, no box, no foreign or calibration gases like in the diffusion testing. So it's really simple, and that's why it is useful and can be applied in patients of any age. So the method, the technical background is also simple. We have a measuring head, a specific measuring head, and you can see that if the patient goes to the filter or the mouthpiece, he can breathe via a small terminating resistor ambient air. And it's requested only to breathe normal. That means resting breathing, no breathing maneuvers. In parallel, this loudspeaker generator generates impulses or forced signals in oscillometry, which are delivered to the respiratory system. And I'd like to point out that only these artificial signals are used to calculate and to determine parameters of the lung. So we are independent on the respiratory activities of the patient, and that's why this method is especially interesting for children and also for elderly. There are two main parameters which are determined. This is respiratory resistance and so-called lung reactance, which is an expression of the peripheral lung. And of course, this system is designed to allow complete spirometry, slow spirometry or forced spirometry on the latest standards. That means this system integrates forced spirometry following the latest ATS, ERS recommendations. In this way, you can have a complete lung function test, and that means that beside forced maneuvers, it is possible to have tidal breathing analysis as well. So the clinical relevance, and I'd like to summarize why it is useful to apply oscillometry. It's compliant to any age starting with 2 years and any degree of severity of disease. That means even severe disease patients can be measured without problems because they only have to breathe normally. So it's a sensitive and differentiated determination of proximal and distal pulmonary obstruction. And here I express obstruction because contrary to flow volume, where you primarily measure the limitation of the flow, here you measure resistance and you measure the obstruction directly. You have an inter-breath advanced analysis in this system, which allows phenotyping of obstruction. That means the differentiation of asthma and COPD, for example. And you get equivalence of the elasticity and lung volume. That means you don't measure lung volume, but you get equivalence of this. This is lung reactance. And as soon as the lung volume is decreasing because of inhomogeneity of the lung, for example, this is reflected in the parameter lung reactance. So you have, and that's also interesting, the evidence of instabilities in the bronchial system, for example, collapsibility. And you have information about the functional characteristics of the extrathoracic airways. This is important if, for example, patients have problems in the upper airways, larynx, for example. So it allows differential diagnostics because it has specific information. So for asthma, to differentiate the central and distal airways and the reversibility of the respiratory system, pre-post reaction after bronchodilator, or to measure and determine a challenge procedure to estimate and determine the degree of hyperresponsiveness. In COPD, you can detect the small and the distal airways, and you have an extended intra-breath analysis. So some details about the oscillometry, and this should show you why it is possible to differentiate the lung in extrathoracic, central, small, and the pulmonary chamber, and also a little bit the chest wall. If you have the patient adapted to the measuring head, this measuring head applies a spectrum of frequencies. That means a scale of frequencies to the respiratory system. And you see these frequencies have physical properties, and the physics say that higher frequencies around about 20 hertz are absorbed and shunted in the central airways, and only lower frequencies are passing the whole respiratory system and appear at the chest wall. In this way, by looking at the frequency response of the respiratory tract, we can clearly differentiate the extrathoracic airways, the central or large airways, the small airways, the pulmonary chamber, which belongs to the peripheral airways, and also the chest wall. And a little bit physiology, and I go back to Weibel, who introduced the morphology of the lung as trumpet. Here you have this trumpet model of Weibel, and we can see that in the central generations of the lung, this goes down to the 8th, 10th generation, there is nearly no change of the cross-section of the airways, even after bifurcation. And only in the central airways, it is possible that you measure resistance. That means respiratory resistance is a major component of the large airways. In the peripheral airways, down to the 25th generation, there are two issues. One issue is that the cross-section of all airways in one generation increase dramatically, that at the end here, at the last generation, you have an area of a tennis court. And in this area, in the peripheral airways, of course, there's nearly no flow any longer. And because of that there is no flow, there's no resistance. And what if we like to discover this part of the respiratory system, resistance is not the right parameter. Here, lung reactance will reflect the lung volume and the elasticity and the inhomogeneity or homogeneity of the lung. So these major parameters, they describe the whole respiratory system, large airways with respiratory resistance, peripheral airways with lung reactance. So now the way of data acquisition, and this is absolutely new worldwide in the system for iOS, that we have an automatism. That means is an automated data recording. We only have to press start, and then data are recorded while the patient is breathing. It is an automated quality assessment. That means the system itself checks the quality of the recordings. That's especially important in elderly and also in children, and tells you if the quality is sufficient. And if not, you have to add trials, which is not so problematic because it's only tidal breathing. And we have the first time a multi-trial architecture. And with this multi-trial architecture, we can discover pulmonary artifacts, and we can also discover artifacts which are related to the adaptation of the patient. That means it's not only that we record at high quality, we can only differentiate artifacts of the pulmonary system, but also of the adaptation. And I'd like to show you a small video, hopefully it will work, that I only press start and the 0 setting of the 𝐂𝐀𝐑𝐄, and then I place the cursor to the left to show that everything is automized. That means if I press start, the patient can go to the measuring head, the patient can breathe, that the breathing cycles will be detected by the system automatically, it will be recorded automatically, and it will be stored automatically, and it will give a quality result after the first trial. I hope the video now is working. You see that I press start, nothing else, and the geo adjustment of the 𝐂𝐀𝐑𝐄, and you see the patient is now at the measuring head, it's breathing, the breathing is detected by the system automatically, and now the recording takes place for about 20 seconds. After the 20 seconds of recording, the system automatically stops and stores test results. Now it automatically stops, stores the test results, and shows the results of this trial at the parameter bar, and also the test results as graph, the intra-breath. And here you have the quality measurement. You see it's bad quality because you have the sufficient quality if you record minimum 3 acceptable trials. I will show you in the next slide. So here you see after 1, 2, 3, 4, 5, 6 trials, the first trial was rejected automatically because the quality was not sufficient. Then 3 trials were okay, even 4 trials. And I added 1 trial which was also rejected because it's significant different to these trials. And now you see that the quality bar is green and that you can stop. If you have questionable quality, you can simply add 1 trial. I think that's so simple, and the most developed lung function test compared to all other lung function tests. So there are 7 important clinical parameters, and if you compare that to spirometry, there are much more than 7 parameters. And if you start with oscillometry, it is possible to work with only 2 parameters. They are most important. That means you can start with 2 parameters and you can add additional information by incorporating more parameters which differentiate the lung. So the first of the important parameters, it's the total airways resistance, R5 it is called. And you can see that R5 concerns and expresses the resistance part of the respiratory tract, the central large airways here. Only if you like, you can have additional information. This is the proximal resistance, the central resistance, which concerns the central airways, including the exothoracic airways. And there is a gap here, differentiated by the frequency dependence of the 5 and 20 hertz. And this frequency dependence, this expresses the small airways. That's a small airway indicator. That means you have a global general information about the large airways, and you can differentiate, if you like, into central airways and the small airways. The second parameter is so-called lung reactance. And as I already explained, it reflects the degree of peripheral obstruction and also the volume, which is accessible by the loudspeaker signal. That means the elasticity and the situation of the peripheral lung and the thorax. You see, this parameter is located here. And there are two additional parameters, which it's so-called resonant frequency or the area index, which gives specific information about the peripheral airways and support the fact to have a pre-post assessment or to have a challenge testing. So I summarize these important parameters. We have the basic parameters, R5 total airways resistance, X5 lung reactance, and as I already explained, already with these two parameters, you can have a comprehensive clinical interpretation. And if you like to differentiate, and this is the power of the oscillometry, you not only get global parameters, but differentiated parameters. Then you look at R20 as central resistance. The difference between R5 and 20, that's the small airways indicator. The resonant frequency, alternative to the lung reactance, and very well applied in pre-post assessments, also AX in the same manner. And there's a global parameter that's called impedance, which reflects the global situation of the lung. So now the simple clinical information, that's really, I have to laugh because it's really simple. You don't have to know anything, because in the report screen, you get an automized classification of the disease. That means the obstruction of central and peripheral airways are classified in normal, mild, moderate, severe, or very severe. That's already classification based on predicted values, which are implemented, automatically provided by the system. And you have a small airways index, which gives you information about the degree of disability of the small airways. That's automatically generated by the system. And you also have an automated interpretation. If you call this interpretation, then, for example, oscillometric tidal breathing analysis is normal range. This is and take care, of course, that's a computer interpretation, and the review of a physician anyhow is required also in classification and small airway index. But I think it's a good starting position if you have the report and automatically you have a classification, you have a small airways index, and you have an automated interpretation. And another important issue in the oscillometry is the graphic presentation of the test results. The test results can be presented in a form that it is equivalent to the Weibel morphology of the lung. So you see in the parameters in the upper part of this graph, you have the situation in the large airways, and here are the parameters for the peripheral part, and you have the situation of the peripheral airways. And that means this clearly reflects the situation of the respiratory system of the morphology, and it's easy to interpret graphical design because it's clear and very quick. You can look at it. So now a little bit to differentiated diagnostics, which is the next step in understanding and using the oscillometry. And here you see this example. This is the situation of the patient before bronchodilation. It was dilated here. You have threshold values for parameters to express the significance of the dilation. And you see here, central airways are affected, peripheral airways affected, and now after bronchodilation, and that's a real clinical case I had, there is a normal central situation, no obstruction of the central airways, and no peripheral obstruction. That means a normal situation. And it's very clear and very easy to classify and to identify pre-post settings. So the next possibility is challenge testing. And with the parameters here, baseline is 1 here. And you see that in the procedure of the challenging, there's an increase of the parameter R5, the total respiratory resistance. And there's also, this is the basic lung function, there's also an increase of the resonant frequency. That's an equivalent of the lung reactance. And you see after bronchodilation, this is the dilation step, it goes back, and also here it goes up. And interestingly is because we made challenge not with forced maneuvers, but with tidal breathing analysis, that, and this is what we expect, the dilatation step gives lower resistance and gives better lung reactance than the normal situation. You will never get such an information from spirometry because of the dilatation of the airways, because of the maximum maneuvers. You can be lucky if after the maximum constriction in the dilatation step, you get the baseline values. So I don't like to discuss the whole slide, but we have strict threshold values for the reversibility pre-post testing, which is comparable to if you have FEV1 of 12% and 200 milliliters improvement of volume. And also the threshold values for challenge testing. That means there are not only graphical signs, but also fixed, and in a lot of studies prove threshold values to determine the degree of reversibility or the degree of hyperresponsiveness. So now about clinical studies concerning the iOS. There are a lot of areas where you can apply oscillometry. This is pre-post assessment. And then, of course, pediatric lung function testing, because we only need tidal breathing analysis. In asthma diagnostics, early diagnostics of lung diseases of asthma. And we can also perform challenge testing, and also the phenotyping of bronchial reaction. In COPD, you have an intra-breath analysis, which allows staging and also phenotyping of COPD, and the detection of expiratory flow limitation. That means in non-invasively and in tidal breathing analysis, the determination of the flow limitation, and it's also very well suited for geriatric lung function testing. The clinical evaluation of disease concerns the upper airways, obesity, epidemiological studies, and also pharmaceutical studies. I was involved in several pharmaceutical studies which give interesting test results based on tidal breathing. So that's a useful tool in the clinical setting in general. Very, very quick. Here in a study which was published to show the management of asthma in children and adults. So what I'd like to express is it's not only for children, it's also for adults and standard lung function testing. And you see that there are a lot of predicted values available for European society or for Asian society, North America and South America, for resistance and also lung reactance and as well. So the evaluation of the test results should be no problem applying to the correct and predicted values which fit to the country. And there's also one slide which should support the differentiation between asthma and COPD. It shows, this small study shows that oscillometry can differentiate between asthma and COPD, even if the airflow limitation based on FEV1 in these patients is identical. It means for spirometry, based on spirometric results, patient groups have the comparable flow limitation, but the parameters of oscillometry significantly differentiate between these two groups of patients and diseases. I'd like to conclude the iOS also in the era of COVID-19. The lung function testing, which is possible with oscillometry, concerns all ages and any severity of the disease. It's a specific differentiation of the respiratory tract. As I said, it differentiates the large central airways from the peripheral airways. And it's completely useful in the follow-up of COVID-19 patients or in the follow-up of long COVID, because it allows infection prevention, especially in outpatients. That means tidal breathing has a lower risk of exposure to viral loads of the SARS-CoV-2 virus. That means that protects the environment of the lung function lab, that protects the physicians, that protects the staff in the lung function lab, because there is no maximum maneuver, there's no forced maneuver which explodes the virus load in laboratories. The aerosol generation is much less than in spirometry. So, and then you have peripheral airways determination. That means an early diagnosis based on tidal breathing of especially peripheral impairments. And it's, as I already said, it's a useful method and the follow-up of peripheral airways after COVID-19 infection. In this way, I'd like to thank you for your interest and say goodbye.